Okay, so let's keep going.
Are we almost done with this section?
Almost. So this is the most complicated portion, so basically this is what I explained to you right here. Remember that we went through the LFTs and the AST and the ALT and the bitter ruling and all that, right? So basically once you determine that the patient has hepatitis, okay, remember if you have hepatitis A, you're going to have anti-hepatitis A virus IgM for the patient to have acute disease. For the hepatitis B, okay, you will have positive hepatitis B surface antigen, but that one by itself is not going to determine if you have acute or chronic. You have to do more exams, right? And remember, for hepatitis C, you have the anti-hepatitis C virus present, and to be able to know if it's acute or chronic, you have to do protein chain reaction to know exactly which type of RNA they have. So it's an immunofluorescence assay, okay? Now remember that the patients can go from recover completely up to chronic phases, and the chronic phases can give you fulminant hepatitis, hepatocellular carcinoma, cirrhosis of the liver, etc. I had a question back there during the break that did not understand why patients in recovery will have the antibody against the surface and chronic patients still would have the hepatitis B surface antigen. Okay? What do you think? Okay. In other words, I know you're lost, but if the chronic patient has the hepatitis B surface antigen, how come the recovered would have the antibody against the surface? So why wouldn't I have the antibody against the surface in the chronic?
Because they're trying to see if they could reappear.
It's not attacking the system.
Because it's still attacking the system. And I gave an example of you have acute bronchitis. And if you recover from acute bronchitis, you're healed, right? But if you go to COPD, which is chronic bronchitis, that doesn't mean that you're healed. You're still diseased, right? You're still, the disease process is still attacking the end organ, which is in this case will be the lung. So the virus itself, even though it's not in the acute phase of the disease, there's still translocations, right, that are still producing damage to the liver. So having a chronic disease doesn't mean that you're completely recovered. And that's the reason why the virus, or in this case the immune system, doesn't develop antibody against the surface in chronic, still active. Okay?
So once it is healed and recovered, then you'll have
The antibody against the surface.
Right.
Okay? Now, basically the vaccinations, remember that we do have a pre-exposure vaccination for hepatitis A. If you decide to go to any endemic area, or if you work in a daycare, if you work, for example, in restaurants or you know, any type of major prophylaxis in military bases, etc. And the hepatitis B, you know that there is basically 3 series. Okay? And the treatment for hepatitis basically is mostly supportive. It's a virus, so you have to go through all the periods of incubation and production phase and enteric phase until this appears. So the hepatitis A, D, and E, for example, basically is mostly fluids.
And then rest, like we don't have that.
Yeah, the problem is that it's not rest. It's just that try to, the same as with any viral condition that could affect the spleen or the liver, you have to avoid highly, you know, sport contacts or physical activity, because you could have splenic or liver rupture, okay? So, what can you do, for example, patients that require, for example, mechanical ventilation, their sedation, most commonly is based on benzodiazepines. So if you're going to choose, for example, between propofol and Versed for them will be better, because you have to try to avoid any medication that has the first pass effect, such as propofol that can induce liver failure. If it's outpatient, if the patients become, for example, encephalopathic, you can use Serax, which is a benzodiazepine as well. Remember that the liver is in charge of the coagulation cascade, right? And patients can go into coagulopathies and bleeding. So sometimes if you have to reverse their coagulopathy, vitamin K will be one of the best. Again, they have one of the byproducts of the protein metabolism that they are unable to break down properly because they have hepatitis. In this case, will be the release of ammonia. So they become encephalopathic, and to be able to excrete that, you can give lactulose. In addition to that, of course, as we mentioned, antiviral medication. We have entecavir, tenofovir, and of course interferon, which you have to advise the patient that can give a lot of like flu-like symptoms to the patient. And of course, it decreases the immune system when patients can have superimposed infections. Okay.
Moving on.
Diverticulitis. Diverticulitis. What they have passion about is the serology. They ask you a lot of questions about serology. So diverticulitis, remember that diverticulitis is no more than inflammatory disease process of the left lower side of the colon. That remember that the theory of diverticulitis is no more than an increased pressure at the level of the lumen of the distal portion of the colon, producing a bouching or like a herniation, and then after that, foreign particles such as fecal matter can go inside, or residual seeds of the food can go inside and produce an infectious and inflammatory process, and that's when the patient have the symptoms. Okay, so basically the patients would have left lower quadrant pain. That is most likely colic in nature, that it could be associated with mucus in the stools, and also hematochezia. Basically the patients have a high risk for perforation, as you can see. 75% of patients due to the inflammatory process, and 25% can go into development of abscess and actually peritonitis and perforation. Of course, the patients that tend to have more incidence of diverticulosis and diverticulitis are patients that are greater than 55 years of age. But if you have, for example, Crohn's disease or ulcerative colitis, you can have diverticulitis before 50 years of age, which is another risk factor. Okay, so as I said, pain, basically located in the left lower quadrant pain. This is an infectious and inflammatory condition, so the patients would have leukocytosis in the CBC with a left shift. The patients would have fever and chills and rigors. And when there is an abscess or perforation at the level of the left lower quadrant pain, the patient would have peritoneal irritation, which is rebound tenderness. Okay, how do you diagnose this disease? Well, typical presentation of left lower quadrant pain. Look at the anatomy of the patient. Most of the time, patients are greater than 50 years of age, and even more that they have had a history of diverticulosis by colonoscopy, since it's the age already of colonoscopy. These patients come with fever. When they defecate, they tend to have mucus production present in the feces, and sometimes hematochezia. And the patients again would have leukocytosis with left shift. All the inflammatory markers are elevated, but that's not an indication of any type of disease process. Okay, so how do you diagnose diverticulitis? Basically, you would do a CT scan of the abdomen on the patient. That's the gold standard and initial evaluation. If you do a KUB, if the patient have already a perforation, you can see different fluid levels and air levels, so free air in the abdomen. I'll show you a KUB right now. Now, even though the most specific way to diagnose diverticulitis is by colonoscopy, you're not going to do colonoscopy on a patient that has an acute diverticulitis, because if the patient hasn't perforated, you can provoke perforation. Okay? So, in a question itself, the most definitive diagnosis for diverticulitis is a colonoscopy, but that is contraindicated in the acute phase. So that's the reason why initial and most relevant diagnostic test that you would do in any patient that has diverticulitis would be CT scan of the abdomen with oral and IV contrast. I want you to look at, first of all, which it comes a lot, you can see it in the patient in the clinical practice, but as well in your board examination, look at the KUV. Remember that the KUV takes the abdomen, but fortunately takes the lower part of the chest as well. If the patient has a perforation, okay? If the patient has a perforation, let me show you a normal KUV. Little small. Let me copy this and put it in the same PowerPoint. Let's take this one as reference, the normal KUV. Okay, so if you look here, basically what you're looking at, this is the ascending colon, this is the gastric bubble, okay, and in some KUVs you also see the descending colon. So basically what you see is the ostras full of fluid, full of air. Okay, and this is the gastric bubble. In some patients, you can see the strain of the descending colon coming down. I want you to now compare that image with this image. Looking at this KUV, you do have the transverse colon and descending colon right here, but I'm not sure if you're able to see that there's a line of fluid. So that is a sign of perforation. Okay? That is called air fluid level. Okay? And when you see that present, it's a sign of perforation. Because air density is lower or lighter than the fluid. Air, when it escapes the colon, goes up, okay, and can produce this air level. Remember that, unfortunately, you have a diaphragm that stops the air, right? So that's the reason why you have like a double diaphragm. You see this area here? That's the normal diaphragm, and this is an obscure level of fluid and air, and makes the appearance on a chest X-ray that the patient has two diaphragms instead of one. So that is a sign of abdominal perforation. Okay? Great. The same way here. You see that you have a line, thinking that this is the diaphragm, and you have another line. Okay? If you think that this is the gastric bubble because you're not sure, let's come to the other side. You have one diaphragm here, and another one here. You see those two lines? That is because the fluid that is, the air that is present in the abdomen occupied by fluid, because all the fecal material and the fluid from the inflammatory process escape the colon and went inside the abdomen, is displacing the air upwards, okay? And is producing this bubble layer below the diaphragm. Okay? Great. So I would have to show you a normal CAT scan for you to understand that these are the normal nostrils of the colon, okay? But here is also occupied with fluid. I don't know if you're able to see that this is a bubble of air, and inside this bubble here, there's fluid. The same way here you have fluid, here you have fluid. So this one right here is completely normal, but all this area is occupied with fluid, and this area is occupied with fluid as well as here, here, and here, and here. Okay? So that is a sign of perforation. You don't know exactly what it is. It could be ascending transverse, descending colon, but you know for sure that there's a viscous perforation. Okay? You had a question somewhere?
Can you go back to the normal KV? Those, the dark circles, right?
These dark circles are air,
Air.
but remember that your feces has anaerobic bacteria normally in your flora, and those produces gas. The reason why you expel gas is because your flora and the content of the food is gas productive, right? So that gas, again, goes up the same because of low density, but that is completely normal. Okay, I can show you more.
How come you don't see the descending?
I mean, it could be because it could be occupied with feces. But for example, I can see the descending right there. See, I don't see the ascending, but I see the descending. Okay? But what you could not see at all is levels of fluid in your abdomen. Okay? And another pattern that I'll show you next week, which is, not next week, the following, the second part of GI, which is part of obstruction. The small intestine versus the large intestine obstruction. Okay? So how do you treat diverticulitis? First of all, you have to, no, not all of them, not all of them. So don't send the patient to the OR right away, okay? There are different levels. If you have a mild peritonitis, the patient doesn't have, for example, signs and symptoms of perforation, you don't have abdominal rigidity, you don't have rebound tenderness, the patient's fever and leukocytosis is decreasing by just putting the patient on NPO and decompressing the abdomen with an NG tube. And you put the patient on broad spectrum antibiotic and the patient is improving the next day, there's no need for surgery. Okay?
That's the obstructions? Or
No, that's as well.
but they say they don't do surgery if you're inflamed, which is
That's
usually.
exactly what I'm saying. You don't send the patient right away to surgery. You have to treat the patient first and see the patient's, how the evolution, okay? So, first of all, you have to put the patient on MPO, okay? Whenever you have an inflammatory or infectious process at the level of the intestine, there's a lot of fluid shifting, okay? And the patients could be dehydrated really, really fast. There's a lot of shifting of fluid to the interstitium, and the patients get thirst space edema rapidly. So because of that, the patients become severely hypovolemic. You have to, for the gut, any disease process in the gut, you have to give large amount of fluids. So you have to put the patient on IV fluids, MPO, pain management, and you have to put the patient on broad spectrum antibiotic, okay? And then select. So, first of all, put the patient on MPO. Once the patient starts improving, in 48 hours, you can start the patient on diet. And that start, of course, with a liquid diet and then advance. Okay, that's tolerated. Now, let's talk about antibiotics, okay? So the antibiotics, remember that in your intestine, the most prevalent flora is anaerobic and gram-negative, okay? So if you're gonna select, let's start with the penicillin, which is the easiest, okay? If you're gonna select penicillin, don't select a penicillin by itself. So oxacillin, amoxicillin by itself is not gonna do it, okay? And if you do a combination of penicillin, this is for a patient that has a mild diverticulitis that can be treated outpatient, okay? So you would select, for example, Augmentin, 500 milligrams, but it has to be combined with either clindamycin or metronidazole, which are the two best for anaerobic gram-negative bacteria, okay? So, for inpatient, if you are going to select a penicillin type of antibiotic, okay, try always to choose combination penicillin, for example, Sozin will be one, okay? And if you're choosing a cephalosporin, try to choose from second generation up. So if you start, for example, with ceftazidime, it has to be combined with metronidazole or clindamycin. But what we do more and more in clinical practice is start with Rocephin, which is a third generation cephalosporin, or cefepime, which is a fourth generation cephalosporin, combined with metronidazole or clindamycin. Okay? So as you can see here. So it's not a set of treatment. So the guideline says that outpatient never start with an aminopenicillin by itself. It has to be combined. So amoxicillin clavulanate, for example, will be one combination, which is augmented, but by itself would not treat gram-negative anaerobic bacteria, because what they actually treat is mostly gram-positive anaerobes. So you must choose a combination with either metronidazole or clindamycin to be able to treat the gram-negative anaerobic bacteria. For inpatient, even though the guideline says that second generation ceftazidime is acceptable, we don't do that. What we do is the second choice. The reason why they try to go slow is because of the high incidence of C. difficile colitis, that the patients can even have more complications than benefit, okay? But actually what covers the best is Rocephin, which is a third generation cephalosporin, or fourth generation cephalosporin, which is amaxipine or cefepime. But always, always, always have in mind that you have to combine these patients with either metronidazole, IV of course, or clindamycin, IV. Okay? And of course, when do you reserve surgery? For which type of patient? For patients that have perforation. Okay? So if you now receive a patient with an abdominal pain and fever and leukocytosis, and you go to the bedside without even doing a CAT scan of the abdomen, and the patient has abdominal rigidity and rebound tenderness, you're gonna send the patient to the OR. Of course, I know that you're gonna consult surgery and all that, but that patient's first treatment would be surgical. Okay? Yes, of course you're gonna get an IV. Yes, you're gonna put the patient on IV fluids. Yes, you're gonna do pain management, fentanyl or morphine on this patient. Yes, you're gonna put the patient on broad spectrum antibiotic, and to be able to go to the OR, at least unacin, which you will cover, okay? Plus flagyl or clindamycin, okay? But this patient will be a surgical candidate. Versus if you have a benign abdomen, only has tenderness but not rebound tenderness on the left lower quadrant, this is a patient that is a candidate for broad spectrum antibiotic IV fluid, and put the patient on NPO and pain management. Okay? All right? So who will you do surgery on? Of course, if you have a patient that has a perforation, common sense, right? Even if the patient has severe symptoms that are not responding after 48 hours, as I told you, you have to do a watchful waiting event first. NPO, IV fluid, pain management, and antibiotic, and reassess your patient. The patient is not getting better, the patient is exactly the same or worse in 48 hours, you do a surgical exploration, okay? Now, if the patient has recurrent attacks of diverticulitis, you have to go in, okay?
So that
And try to remove, correct, okay? Now, if, for example, the patient has a phlegmon, which is an abscess, you have to also bring the patient to the OR, because abscesses would not be treated by antibiotic. You have to drain first before the antibiotics can work, okay? Of course, if the patient has a tumor, you have to do a surgical resection. Now, let's talk about this because it tends to come a lot in more examination. Patients with diverticulitis, okay? When there's a chronic or recurrent diverticulitis, sometimes the patients develop fistulas. Fistulas from the colon to the bladder, okay? And not only, of course, the patient has recurrence UTI, but in addition to that, the patients have what's called pneumaturia. When the patients are urinating, there's not a normal bubble production. This is like The water of the toilet seems to be so foamy, like if you're putting detergent into the water, okay? That is called pneumaturia. Pneuma means air, like pneumothorax, right? Pneumaturia, okay? That means that there's a presence of a fistula between the colon and the bladder, producing before you see the pneumaturia, you would see the patient have recurrent UTI as well, right? But the air coming from the colon passes to the bladder and produces a large amount of foaming in the toilet, okay? And that is a surgical indication because, as you can imagine, the bubbles don't hurt, right? But the problem is that this fecal material or this anaerobic bacteria constantly going into the bladder will produce severe pyelonephritis and renal failure, okay? So that's the reason why we have to bring the patient into the OR. If you see at any point, pneumaturia, okay? Another one is cholecystitis. You know that cholecystitis basically is a right upper quadrant pain. The most common risk factor is having calculi at the level of the gallbladder. You know that the major risk factors for cholecystitis and cholelithiasis are the patients are female, that they're 40 years of age, that they have family history, and they tend to have consumption of high-fat food, right? So this is patients can have two types of cholecystitis: calculous cholecystitis and acalculous cholecystitis. Let me talk to you about acalculous cholecystitis. The same way the hepatic artery can be triggered when the patients have any ischemic process or any hypovolemic process, the gallbladder can also go through ischemic stages, not receiving proper amount of perfusion or blood supply, and produce an inflammatory process. So what I'm trying to tell you is that patients that are critically ill, that at any point have had any hypotensive or hypovolemic state, not only the patients can have elevation of the liver function test, but the patients can also end up with cholecystitis, okay, complicating the case of this critically ill patient and producing inflammatory process without a visible calculi. So if a patient now comes in and is in the ICU, for example, imagine that the patient had a traumatic brain injury, okay? And the patients were intubated. And through the process of ICU state, the patient remains intubated, and the patients have a hypotensive state, and you give fluids to the patient, and the patient doesn't recover, and you put the patient on vasopressor support. I'm just giving you an example of ischemic process. That gallbladder can suffer ischemia and go through an inflammatory process. And the patients, of course, they're sedated, intubated, they're not going to manifest with a right upper quadrant pain, but there you would see not only LFTs elevated, bilirubin elevated, but also when the abdomen will be distended, the bowel sounds will be decreased, and you would see high pressure being used in the ventilator, okay? So basically the patient becomes hypoxemic with a distended abdomen, with a liver function test elevated, and when you do an abdominal ultrasound, or when you do a CT scan of the abdomen, due to that ileus paralyticus that is present and the liver function test being elevated, you find that the patient has a sludge gallbladder, or that the patient has surrounding the gallbladder fluid, which is called cholecystitis, or fluid surrounding the gallbladder, or pericolic fluid, okay? That is no more than gallbladder edema produced by ischemia of the gallbladder because the patient went through a process of ischemia. Do you understand? And that could happen to any critically ill patient of any kind. Either if it was a CABG patient, that now the patient is on epinephrine and levofed, and dobutamine, and the patient is critically ill, even if the patient has recovered, sometimes the patients would have a calculus cholecystitis due to the ischemic process that the patients went through before, okay? All right, so I want you to see examples of a calculus cholecystitis. For example, if you have a prolonged fasting patient, that's why we, or another condition why we incorporate nutrition initially. Any shock patient, any patient that has any major complication of an autoimmune condition, or again, to summarize, any major ischemic process of the gallbladder. And how do you treat that? Unfortunately, the only way that you can treat a critically ill patient that is going through acute cholecystitis is to have cholecystostomy, to basically drain out the bile through an ostomy at the bedside before you can take this patient to the OR and have a cholecystectomy. Okay?
That's for A calculus.
For acalculous cholecystitis. So acalculous cholecystitis, an obstruction of the common duct, in patients that are critically ill, that you do an ultrasound or a CT abdomen and you find no calculi, is highly prevalent due to ischemia of the gallbladder by a prior hypovolemic or hypotensive episode. Okay? So again, right upper quadrant pain associated with vomiting, and what is the major sign that you remember from a health assessment? That when you press on the right upper quadrant, on inspiration, the patients can continue taking a deep breath, and that is called Murphy's sign. You can elicit that with the ultrasound probe itself, okay? And of course, the patients will have guarding and all that, okay? Remember that elderly patients are very atypical. So what will you see on diagnostic evaluation? Well, leukocytosis, because it's an infectious and inflammatory process, but that is not definitive. You would see, again, as I said, liver function test elevated, and bilirubin in this case will be which type? Direct and conjugated, okay? Now, you would have amylase elevated, because remember, amylase is present in the intestine, in the saliva, in the pancreas, so it's not a definitive value, but lipase would not be elevated. Now, how would you diagnose? Which diagnostic test would you use initially for cholecystitis? Ultrasound, okay? And you can even elicit the Murphy sign with it. And as I can say, you can see very cholecystic fluid. So fluid surrounding the gallbladder that basically tells you the patient has edema, or it could be reported as the gallbladder doesn't empty appropriately. That's called flushed gallbladder, I'm sorry. But in the patient that is not critically ill, you most likely will find a calculi, because lithiasis is the major etiology of cholecystitis, okay? What else would you do? Well, you could do a CT scan of the abdomen, as I said, but the most specific diagnostic test would be the cholecystography, which is called the HEA scan.
And was that like a CT?
It's a CT, but it's basically using, it's not iodine, but it's basically gadolinium. That is highly specific, right? Basically colors all the ducts of the gallbladder, okay?
So the gold
It's like a radionuclide type of contrast.
What's the most?
It's the most specific. For example, you might have the clinical signs and symptoms of cholecystitis, and when they do a liver ultrasound, a gallbladder ultrasound, you wouldn't find any specific sign of cholecystitis, not even positive Murphy sign. But if you have a highly suspiciousness of cholecystitis, you can do the HEA scan, okay? Now, but it's once, even though we do it over and over and over in clinical practice, once you have the diagnosis of cholecystitis by an ultrasound, there's no need to go to pupillar scan. You can go straight to surgery.
So gold standard ultrasound number 1.
Initial and gold standard.
But the
Okay.
other one,
But the other one is more specific, actually confirms the diagnosis.
and you said it uses.
When there's false negative, when there is negative results and you have highly suspiciousness by clinical findings, yes.
With the that other example, the most specific one,
Cholecystography.
that one uses a gamma, what is it called?
It's a gadolinium. It's a radionuclide
That's the one
contrast.
that you use that for other patients with kidney problems that
The same that you use for MRI, MRA.
Because it's less damaging to the.
Correct.
Like the
Gadolinium.
what is gadolinium?
G-A-D-O. Okay? So how will you treat the patient again? You don't need to bring the patient to surgery. I mean, there's actually, if the patient, it really depends on the amount of stones and the diameter of the stones, okay? If the patients are not, in this case, it's not like you, nephrolithiasis that you can spell the stone by yourself, but the GI system is able to destroy them, okay, sometimes when they're soft and bile content, okay? So sometimes you could also do a watchful waiting event of putting the patient on supportive therapy, only MPO, putting the patient with an NG tube and antibiotic, okay? So when you do the ultrasound, if the stones are more than 7 millimeters and there are multiple stones, you bring the patient to surgery. If the stones are scars, like 2 or 3, and they're less than 7 millimeters, you could do a watchful waiting event, okay? Now, recurrence episode, because there is also existence of chronic cholecystitis, okay? When there's repetitive episodes, of course, you have to bring the patient for surgery. Now, the most definitive treatment, of course, will be cholecystectomy, but you don't have to do cholecystectomy in all the patients, okay? Now, antibiotic treatment, exactly the same as tuberculosis. You don't have to memorize any other choices. So bringing the patient into the hospital and treating the patient for cholecystitis. Choices, for example, if you choose penicillin, you have to choose a combination penicillin. In this case, will be Solzing. But remember, it cannot be alone. You have, because Solzing only covers maximum gram-positive aerobes and Pseudomonas. It doesn't cover gram-negative. So you have to combine with either metronidazole or clindamycin, okay? And if you're choosing, for example, cephalosporins, you could choose 3rd generation, 4th generation, or Cefin plus Flagyl, or you could choose Maxipin, Cefepime plus Flagyl, or you could choose Unacin plus Flagyl.
Isn't alcohol and heavy abuse of alcohol one of the other causes of cholecystitis?
It's a risk factor. It's a risk factor. Risk factor. But the majors are genetically predisposition, so familial predisposition. If you have a 1st-degree family member that have had cholecystitis, you are at risk. If you're a female more than 40 years of age, you're at risk. And if you're a type of person that likes to eat fat content, like fatty food, and when I'm saying fatty food, doesn't have to be McDonald's, you know, it could be Cuban food.
Fried chicken,
Why is it that they can?
Exactly. Yes. Now, once you, she's asking me about dumping syndrome. Even though dumping syndrome is most prevalent when you do any type of gastric surgery, right? Because you actually interrupt the gastric outlet. Patients with cholecystectomy can have dumping syndrome because remember the function of the gallbladder is to be able to group in micelles the fat and eliminate them. So you don't have that anymore, so the vials cannot be processed and metabolized properly, and the patients dump by osmosis. Okay?
How come GI, gastric bypass patients, I don't like cholecystectomy oftentimes? At least I know several who just gone straight to cholecystectomy.
Because the stomach is not connected to the gallbladder at all. The duodenum is. Now, so any question about cholecystitis? No?
So Solzing, you have to give it with either metronidazole or clarithromycin.
Again, going back to your antibiotics in pharmacology, remember that penicillins, you have aminopenicillins that when they're single, they're non-combined, okay? They only cover gram-positive. As you advance in the combination, you cover more Pseudomonas and a little bit of gram-negative. To be able to cover all the gram-negative and anaerobes, and mostly the ones that are enteric, that lives in the colon, you have to choose either flagyl or clindamycin. So never choose oxacillin, amoxicillin, tircocillin by itself. You have to combine them. And plus, on top of that, you have to choose metronidazole or clindamycin with it. Okay? If you're choosing a cephalosporin, for example, cefazolin by itself is not going to do it. It's the first generation cephalosporin. So you have to choose from third to fourth and combine them with flagyl or clinda. Clinda is not in your PowerPoint, but it's a choice. Okay? So pancreatitis, let me tell you, the most common risk factor for pancreatitis is called lithiasis. So remember that the gallbladder has a connection to the pancreas and has a connection to the duodenum, as well with the liver. So the liver has multiple ducts, right? One to the gallbladder, one to the pancreas, one to the duodenum. So you can have retrograde inflammatory process. If you have any obstruction at the level of the gallbladder by a stone, producing inflammatory process repetitively in the gallbladder, which is called cystitis, can produce pancreatitis and can produce duodenitis, and backwards, okay? So have that in mind. So, other causes of pancreatitis that follows cholelithiasis is alcohol abuse, okay? Another cause of pancreatitis that follows cholelithiasis and alcohol abuse is hypertriglyceridemia. You memorize in the ATP3 guidelines that when it's over 500, you don't treat with statin and you treat with fibrinic acid or niacin because of the risk of pancreatitis, right? So that's the reason why I need you to remember that. Others, they're not the most common. Others could be, look at ACE inhibitors as cause of pancreatitis, okay? You could have, of course, patients that have any type of chemotherapy or sulfa drugs. If you have any type of infectious process can give you pancreatitis. So pancreatitis by itself is not due to alcohol. Everybody labels people, okay? Inherited conditions such as in cystic fibrosis. Remember that cystic fibrosis is a recessive condition that affects the chlorine channels, okay? That will affect exocrine glands, and all the mucus production glands will be affected. Okay, not only the patients will have high secretions at the level of the lung and malabsorptions, but the pancreas is also affected. So all the exocrine glands are affected, producing pancreatitis. Remember that the most common cause of pancreatitis is cholelithiasis. Now, what else can produce pancreatitis? Well, we can use ERCP, right? Endoscopic retrograde cholangiography for a patient that has cholecystitis, and which is PPTA scan, the HEDA scan, and that scan can produce pancreatitis because it's basically a procedure going through it that could produce an inflammatory process at the level of the ducts, okay? Cancer, of course, it makes sense. Metabolic condition, hypertriglyceridemia, don't forget that one, even though hypercalcemia can also do it, and alcohol abuse, patients that have pregnancy or transplant. But the three that I want you to never forget is the leading number one is cholelithiasis, second, alcohol abuse, third, hypertriglyceridemia. So yes, alcohol is not the leading cause of pancreatitis. Even though you're coming from Key West, you got it. Okay? So what would be the signs and symptoms of pancreatitis? Everybody knows this. It's going to be gastric pain that radiates to the back, right? That the patients can have or not, depending on the severity of the disease, rebound tenderness or rigidity. That the patients, when the patients are sitting and up or leaning forward, that reduces the pain. And associated with nausea and vomiting and all the signs and symptoms of, ileus paralyticus that they can have due to the major inflammatory process. Now, I want you to remember the pancreas is at the level of the epigastrium. The body is in the epigastrium, right over quadrant is the head, and the leftover quadrant is the tail. So not all the patients come with epigastric pain radiating to the back. Many other patients come with the signs and symptoms of cholecystitis and tends to be pancreatitis. In addition to that, if you have at any point any rupture, okay, or the viscous, because that can produce so much inflammatory process that produces peritonitis and rupture. But in addition to that, the pancreas can produce a hypercoagulativity state, okay, that the patients can have from thrombosis to bleeding. Because again, pancreatitis is qualified as a major systemic inflammatory response to the body that can produce major activation of the coagulation cascade, and the patients can lead to thrombosis and even up to the point of DIC. When this happens, the patients can have signs that you remember from health assessment, I hope, that is bleeding at the level of, it's basically retroperitoneal bleeding, okay? That the patients would have like a hematoma surrounding the umbilicus, which is called the Grain sign, Coulin sign here, and Grain turning sign at the level of the flank. Cooling is the umbilicus. Okay, so how do you diagnose pancreatitis? Well, let's start with a blood test first. Of course, you're gonna have in the CBC leukocytosis. You might have a major dehydration state. Remember, it's a major fluid shift at the level of the interstitium. What else? Of course, the patient's gonna have all the inflammatory markers elevated, serrate, CRP elevated, but they're not highly indicative. Now, in addition to that, you do amylase and lipase. Remember that amylase is sensitive, but it's non-specific. But the patients would have a lipase. This is the normal value, 14 to 280, okay? They're gonna have severely elevated values, more than 280, of course. Now, what else can the patient have? Well, because of the major electrolyte shift that is happening at the level of the intestine due to pancreatitis, the patients can go into hyperparathyroidism, having hypocalcemia, okay? And that's an indication of poor prognosis. Having hypocalcemia less than 7, you know that you can have not only muscle weakness, but in addition to that, you can have the trousseau, which is when you take the blood pressure, the patient have a muscle spasm, and the shop stick when you tap the face, okay? And what else? How do you visualize the pancreas to be able to see that there is also edema surrounding either the head, the body, or the tail? CT scan of the abdomen with IV contrast. What will you see on the chest X-ray?
If it's swelling, maybe we have the elevation.
You can have elevation of the diaphragm. What else would you have if it's a major fluid shift?
Oh, the line?
Pleural effusion. Only that, pleural effusion. Now, this disease process, when you go through pulmonary, you're gonna understand it better. Pancreatitis producing a severe inflammatory reaction, okay, can lead to leakage of fluid anywhere in your body, including in the alveoli. So that impairs the gas exchange. Patients go through major hypoxemia and chanting, and the patients end up in adult respiratory distress syndrome because the pneumocytes are unable to produce surfactant, and there's major lung collapse due to pancreatitis. So pancreatitis is one of the leading causes of ARDS. Okay?
Wow.
So that's the reason why once you diagnose a patient with pancreatitis, based on the ransom criteria that you will memorize, okay, you admit the patient into a regular floor or into ICU, because that determines the prognosis and mortality of the patient, okay? So what would the patient have? Hyperglycemia? Because the inflammatory process, cortisol is released, so the patient will have hyperglycemia. So this is an infectious state. Why LDH? Why can you release LDH? Didn't I just said that pancreatitis can actually not only elevate diaphragm, but activating inflammatory cascade and complement and coagulation cascade, the patients can bleed. There's a high process of ischemia, lactic acidosis. In addition to that, produces a major hypoxemia and shunting at the level of lungs. Patients cannot produce a normal gas exchange, so hypoxemia and ischemia of the bowel and the lungs will produce lactic acidosis, okay? And of course, if that is present, you should imagine that you're not gonna see this patient in a regular floor, right? So, basically what we see is, when we look at the patient, is what's called Ramson criteria. So basically, depending on how many risk factors the patient have, the mortality will be higher. So the only thing that you have to know so far is that Ramson criteria is a predictor of mortality. Okay? So, basically we look at the patient on admission. Look at this. We look at the patient on admission. And we look at certain values upon admission. And then, after 48 hours, we reevaluate the patient. And based on that, we, again, say, okay, the patient on admission has critical values, the patient's going to the ICU. 48 hours later, we'll reevaluate based on those values, and we decide to keep the patient in the ICU or to transfer the patient to the floor, or backwards. Imagine that during admission, the values are not critical. You keep the patient in a regular floor, but 48 hours later, the values are worsening. Now is the time that you decide to bring the patient into the ICU, because that's the patient that could deteriorate quickly, okay? So again, Ramson criteria is the prognostic value of mortality, and depending on the values, you will admit the patient in the regular floor or send the patient to the ICU, okay? So, if you're more than 55 years of age, to start, that will be a point, right? So, look at the risk factors. The higher the number, the higher the mortality, okay? So, if your WBC is more than 16,000, you give another point. Glucose, if it's more than 200, you give another point. LDH, lactic dehydrogenase, if it's elevated, that means that you're not going the right route, right? AST is already affecting the liver. Not only the pancreas has an inflammatory process, but it's already obstructing one of the conducts of the liver, producing shock liver, okay? So this is not no more than a mnemonic, that if you want to memorize it like that. But basically you look at age, WBC more than 16,000, glucose more than 200, LDH more than 350, and AST more than 250. If you have those values, you're not staying in the regular flow. Okay? Now, you reevaluate the patient 48 hours later, and it's common sense. Listen to me. Okay, if you're more than 55 years of age, will you have the same prognosis in any disease process if you are 40 than if I am 78? So it's common sense that the older you are, the worse the prognosis, right? If you're coming with a 12,000 WBC, anybody can have 12,000, even if you break your leg, right? But the higher the number, the higher the infectious process. If your glucose are so elevated, that means that the body is going through a major stress, releasing cortisol, right? And if I'm not controlling properly that glucose, the healing process of any organ will be deteriorated, right? If you're already releasing LDH, what does that mean? That you're going through an aerobic cascade, right? That means that the tissue is going through ischemia. So that's not a good prognostic value, right? And if your AST is already elevated, I'm not saying that you have an obstructive condition, but since AST is most likely related to ischemic process, hypovolemia, I'm just saying that this inflammatory process is already damaging the hepatic artery. by hypovolemia or hypotension, etc. Yes.
So all of those under admission get 1 point per?
Yes.
Okay.
The higher the points,
So
the higher the mortality. So therefore you're gonna be, for example, if you have only PH and WBC, so those two are not as relevant as if you have already LDH elevated and AST elevated. So you have to be, you have to use your judgment. Only 2 points is not gonna be significant for you to go to the ICU versus if you have them all, okay? Now, 48 hours later, think about this. If your hematocrit dropped more than 10%, what could that be?
Dehydration? No, sorry, overload.
Overload state. Your hematocrit will drop because remember, you have a major fluid shift. If you're already having that, that means that you're deteriorating. BUN increases. If your BUN increases, it's basically telling you the same thing. That means that intravascularly, you're depleted. And the amount of fluid that I'm giving you is not enough. These people tend to need 6 liters or more, okay? They have a major fluid deficit. Calcium less than 8, which is normal, 8. Less than 8, and of course you're gonna look for the iodine and calcium because these patients tend to be in catabolic state already and the albumin will be low. So if you're having hypocalcemia, that means that you're already going through a major ischemic process affecting your parathyroid, okay? And affecting your kidneys, which is another organ that participates in calcium production, along with PTH, right? The PO2 is less than 60. You're already in the classification of respiratory failure. Base deficit. What is base deficit? When you have an ADG, you have pH, you have PCO2, you have PO2, you have bicarb, and you have the base excess, right? If you have a patient, let me put you an example of that, 7.2. Imagine that the patient has 44, and this patient has 54, and the bicarb is 19, and the patient has a deficit of 6. This patient is in metabolic acidosis, right? With a major base deficit. The normal deficit is -2, +2. So this patient is, you will understand this better when we do metabolic acidosis and we calculate the anion gamma and all that. So this patient is basically having metabolic acidosis. It's not telling you anything other than that, okay? This patient is having metabolic acidosis due to the ischemic process, to the sepsis of the pancreas, okay? When you basically do a fluid deficit on the patient on the intake and output, the patient has a major fluid deficit, okay? And as I told you, these patients tend to have at least a negative 6 liters. So this is the mnemonic. So if you use your judgment, you don't have to memorize this. Basically, all the values that are telling you that the patient is deteriorating, is not improving. The patient, for example, the patient comes in with hemoglobin of 12 and hematocrit of 24.2, okay, it tends to be double, by the way. So this is the patient entrance on admission. And 48 hours later, you have your hemoglobin of 10 and your hematocrit of 20. Let's put 19. This is an indicative value, not of anemia, not that the patient is bleeding. It's an indicative value that the patient is in volume overload state. not only, I mean, it could be, if it's an isolated value, let's answer your question. Yes, it's true. If you only have your hematocrit dropping more than 10%, yes, of course, it could be the amount of fluid that you're giving to the patient. But it's an isolated value. But if on top of that, I have that my patient has an LDH or lactic acid, so if you don't have the LDH in your chemistry, but you measure the lactic acid, and now the lactic acid from 1.5 went up to 3.6, what does that mean? That means now that this is not an isolated value, that I'm giving a lot of fluid. This combined with this means that the patient is not going the right route. The patient is going through an aerobic cascade because of ischemia. That patient has a poor prognosis. Do you understand? Okay? So you need to memorize this? How do you treat the patient? Lots of fluid. Lots of fluid. The first 24 hours, of course, the patient will be critical. You have to put the patient on MPO and allow the enteric organs to rest. Once the inflammatory process passes, you have to start feeding the patient. Okay? That is actually indicated. You have to continue because remember, calculus cholecystitis can also worsen this process. Okay? So there's also different levels of pancreatitis. There are pancreatitis that you don't need to put the patient in the ICU. It's mild pancreatitis. And how do you treat those patients? Again, you put the patient on MPO, rest the enteric system, the bowel, including the pancreas and everything, the gallbladder and everything. And then once the pain is improved and the leukocytes are decreasing and the fever is improving or disappeared, then you start feeding the patient. And IV fluids, you can't forget the IV fluid. It's the most important part. What else? Pain management. Remember that, Remember that morphine tends to close the sphincter of Oddi, okay? And that could affect not only in pancreatitis patients, but also in cholecystitis patients. So patients can actually have a worsening of the condition because of blockage of the common duct by the constriction of the sphincter of Oddi by morphine. So you use Dilaudid, you could use fentanyl, you could use other narcotics, okay? Due to the spasm that produces, okay? So,
Don't recommend morphine, recommend
You don't give, it's contraindicated, right?
Yeah.
it is contraindicated. So patients many times request the morphine, but you have to understand that morphine can constrict the sphincter of Oddi, and that can produce more damage because there's no, for example, the gallbladder cannot empty properly, and the patient has cholecystitis that worsens the process, okay, of recovery, and the same thing happens in pancreatitis. So have that in mind, okay? So at least in the acute phase, hold the morphine, use any other narcotics, okay? And that could be a question too. What else do the patients have the same in cholecystitis? They can have vomiting, so you could use medications that increases the transit time. For example, promazine, or you could use Reglan, or you could use also Sofran. Remember that Reglan is an anticholinergic, so the patients can have dry mouth and also as a major side effect, involuntary movements. And for antibiotic. Now, that doesn't mean that you're not able to use the same antibiotics that you use for diverticulitis and cholecystitis. Yes, but you have to use your rationalism, right? Your comprehensive, your skills. If the patient has a severe pancreatitis, based on perhaps some criteria, you have to admit this patient into the ICU. Now, the antibiotics that you use as combination, instead of using Zosine, instead of using Rosefin or Cefepime, you would have to go a higher up level and use, for example, the carbapenems, imipenems, or Cyvox in combination with your Flagyl or your clindamycin. Yes.
Did the guidelines perhaps change about the MPO status as long as perhaps the patient can tolerate intake and they don't necessarily have the signs and symptoms of vomiting? I'm only asking this because when last semester, one of the rotations, patient had pancreatitis, and I asked about that, and they said that the patients, if they tolerate it, they're not.
In mild pancreatitis, the first 24 hours, you're gonna be MPO, okay? After the first 24 hours, if it's a mild pancreatitis, the symptoms are going to improve. Once you put a patient in bowel rest, and you put the patient on IV fluids and pain management, the symptoms are going to improve, okay? And after that, of course, you start diet, nutrition. And on the contrary, the longer you prolong the patient being on NPO, the worsening the condition, because that means that the gallbladder cannot contract properly, and that can produce more inflammatory process in the pancreas. But in the first 24 hours, you would have to put the patient on NPO, okay? But early nutrition is indicated by guideline when you have mild pancreatitis.
Before they used to have you MPO forever.
Exactly. Not anymore. Okay? The same with the critical stage. 48 hours later, once all the numbers are getting better, okay, and the patient, the AST, the calcium, the BUN, all those numbers are getting better, you're going to start nutrition. Okay? Now, what else, since remember, cholelithiasis is the leading #1 cause of pancreatitis, what else can you do for this patient? Of course, you have to remove the stones. If the patient is in severe pancreatitis in the ICU, critically ill, you're not going to do so, right? But if the patient has mild to moderate pancreatitis, once the acute phase finishes, you can also do ERCP and get the stones. Now, remember that ERCP by itself can produce pancreatitis. So don't do it in the acute phase, okay? And also, since again, cholelithiasis is the #1 leading cause of pancreatitis, you could also do cholecystectomy.
Which one is the ERCP?
It's called retrograde endoscopy, cholangiopancreatography. Okay? Basically, you go through the gallbladder to the pancreas. Okay? So hepatic artery, gallbladder, so liver, gallbladder, pancreas. That's the only way to do it. You have to go retrograde. Or through the duodenum to the pancreas. Correct. Yeah, because if the patients are critically ill, you can remove the stones first, or you can drain out the pressure and the fluid first before you take the patient to the surgery.
What is that procedure called?
What is
That procedure?
What is it?
The same thing. It's the same thing. Any questions? Any questions? So, remember that I'm going to release 50 questions. Of course, it's going to be more on renal than GI because there's only one portion of GI. I'm going to send you a lot of questions to practice.